Thank you, Beihing, for the introduction. It's a great pleasure for me to be here to talk about overdiagnosis in cancer, a topic that I have been working on for several years, together with Dr. Salvatore Vaccarella from the International Agency for Research on Cancer. Our studies were mainly centered around 5 questions, which also outline this talk today. What is overdiagnosis? Why does it occur? How large is the impact? Why does it matter? And what do we do to deal with it? So the first question, what is overdiagnosis? Let's start with a general illustration of the natural history of cancer. When a patient comes to our hospital to seek treatment because of symptoms, usually the cancer has already progressed to an advanced stage with very poor survival. One of the most important strategies in cancer control is cancer screening. The aim is to detect and treat cancers in a preclinical stage to improve the survival of cancer patients. And the key for cancer screening to work is to intervene during the lead time. There are multiple benefits of cancer screening. It can reduce cancer deaths, and for some cancer types, it can also reduce cancer incidence. It can reduce the severity of the disease, making the treatment less invasive and give people more choices. But it also has multiple harms. And one of the most important harm is overdiagnosis. There are 2 scenarios of overdiagnosis. The first one is if death due to other causes occur before cancer can cause death. And very often it can occur even before cancer can cause symptoms. And another scenario is that for some cancers, they progress very slowly, and some of them could even regress. And so in a person's limited lifetime, the cancer may not cause symptoms or cause death. So this is the very long definition of overdiagnosis. The labeling of a person with a disease or abnormal condition that would not have caused the person harm if left undiscovered, creating new diagnoses by medicalizing ordinary life experiences or expanding existing diagnoses by lowering thresholds or widening criteria without evidence of improved outcomes. Individuals derive no clinical benefit from overdiagnosis, although they may experience physical, psychological, or financial harm. In short, overdiagnosis is the diagnosis of a cancer that will not cause symptoms or death. There are 2 components of overdiagnosis. One is cancer indolence and another is competing mortality. These are corresponding to the 2 scenarios we just talked about. I will use thyroid cancer and lung cancer as examples of overdiagnosis illustration. The second question, why does overdiagnosis occur? There are 3 prerequisites. The first one is existence of a cancer reservoir. When we think about cancer, we often think of it as a rare disease. In the cancer statistics, we would say how many cancer patients per 100,000 population. But actually, the pool is much larger than we think. Autopsy studies found an average prevalence of 13% for papillary thyroid cancer, almost 9% for prostate cancer, and around 1% for lung cancer. So the pool of subclinical detectable cancers actually is very large. And the second prerequisite is availability of sensitive diagnostic technologies. And the third one is activities leading to detection of the cancer reservoir, such as increased surveillance, opportunistic and organized screening, and incidental detection. In this regard, we conducted a retrospective cohort study in our medical center. to assess the association between detection route and mortality from thyroid cancer and competing causes. We recruited all the patients diagnosed with papillary thyroid cancer during 2011 to 2018 and followed them up with a median of 5 years. And we can see that during the past decade, the numbers and proportions of papillary thyroid cancer patients which are incidentally detected have been increasing rapidly. But the number of the non-incidental group remains stable over time. We also used cause-specific hazard models to look at the impact of the detection route, and we found a very low hazard ratio for thyroid cancer mortality among those incidentally detected. Some people might argue, oh, maybe this is a benefit of early detection to reduce mortality by early detection. But when we confined the analysis to stage 1 patients, which are all early diagnosed, we found similar results, implying that the mortality risk among the incidental group is extremely low. And this also suggests that we may have diagnosed and treated a lot of indolent cancers that would not die anyway. So how large is the impact? Let's look at thyroid cancer, for example. Over the past decades, thyroid cancer incidence have been increasing very rapidly in a lot of countries all over the world. And the mortality rates remained stably low over time. Sorry that I don't have the data for Malaysia at the moment, but I hope that I can have the opportunity to seek collaborations here so that we can know the situation here. But the meaning of this picture is to raise alarm because the phenomenon is not only influencing high-income countries and is expanding very rapidly all over the world. This is the age curve of thyroid cancer. We can see that the age curves have been changing rapidly over time. We know that cancer is a chronic disease. It usually takes decades to progress, so it's very unusual to see abrupt changes in the age curves in just a few years. So we used the multi-stage model of carcinogenicity and the historical patterns of multiple registries all over the world to estimate the historical age patterns if overdiagnosis had not occurred. And then we estimated that almost 1 million individuals were overdiagnosed only in 5 years in 26 countries. And the proportion ranged between 40% to 90% of the diagnosed cases, a very wide range. And it's very important to note that the issue of overdiagnosis is not only an issue in high-income countries. We also found spatial temporal variation in thyroid cancer overdiagnosis within countries such as France and China. Here we can see that the numbers and proportions of overdiagnosis increased over time, and they are affecting different age groups and different departments in a different magnitude. For example, the impact is below 40% in one department and can be as high as almost 90%. Similar in China, we found a very large difference between urban and rural areas And the large spatial heterogeneity is mainly contributed by papillary thyroid cancer and is highly correlated with socioeconomic indicators. One concern is whether there's a role of risk factors on the time trends. It's very difficult to answer this question because given the large impact of overdiagnosis on the incidence trend, any effect of risk factor might be obscured. So we thought whether mortality trends can help us to give us some clues. So we conducted an age period cohort analysis to look at the mortality trend. And we found decreasing mortality trends in most countries. And the birth cohort effect, which can represent the role of impact factors, risk factors, have been declining in all countries. So this does not support the strong role of risk factors in the current epidemic of thyroid cancer. So previous studies have found different overdiagnosis estimates for several cancers. And we can see that there's a very wide range, for example, for low-dose CT lung cancer screening. So we wanted to know why. We conducted a systematic review to look at the overdiagnosis estimates in different clinical randomized controlled trials. And we calculated two indicators, PS and PA. The numerator is the same, is the excess incidence. The difference in lung cancer cumulative incidence between the screening and control arm. Well, the denominator is screen detected lung cancer cumulative incidence in the low-dose CT arm for PS, and all lung cancer cumulative incidence in the LDCT arm for PA. And we found that 40% of the variations in PS and PA can be explained by follow-up time after last screening. We further obtained detailed information from two specific trials, NLST and LUCY. One is from the US, another is from Germany. And we found an annual percent change of around 4% for both trials. And the PS estimates were around 3 to 4% lower in the NLST because they used different screening strategies. And we estimated that PS would plateau at around 2% for NLST and 9% for LUCY. We further obtained the individual level and long-term follow-up data from the NLST trial to explore the participant characteristics associated with overdiagnosis estimate. And we found that overdiagnosis increased with age and lower life expectancy. And the estimates differed by histological subtype, notably the adenocarcinoma. So why does it matter? Because it can cause a lot of unpleasant consequences. One is heavy and harmful treatment, and another is psychological impact. The cancer labeling is devastating for cancer patients and their families. It can also cause financial toxicity for both individuals and healthcare systems. So there's a vicious cycle of overdiagnosis. When there are greater access to healthcare in the advanced people, there will be more overdiagnosis. It can cause a false impression of improved survival, which can cause more incentives to get more healthcare services. This cycle can not only cause a lot of unnecessary harmful treatments, but can also cause less healthcare available to those really in need. Like the famous inverse care law. The inefficiencies and deregulation of healthcare systems, like the offering of non-indicated screening services, or increasing indiscriminate use of imaging and advanced diagnostic techniques, or greater access to unregulated care, can cause harms outweighing benefits. So we want to know how many healthcare resources are being wasted because of overdiagnosis. So we conducted an economic evaluation to answer two questions. One is what percentage of the overdiagnosed patients is overtreated, and how much of the economic burden is caused. We utilized multiple data sources in France to answer this question. The French health insurance data set and the cancer registry network, and also the complementary information from medical records were integrated to estimate the cost of thyroid cancer treatment. And we found for in France, the treatment for thyroid cancer patient is around 6,000 euros per capita. And in total, during these 5 years, in total there are around 200 million euros for the whole France. There are two types of incidental findings in this study. We didn't consider the first one is incidental findings after surgery for benign diseases because the cost is mainly linked to the treatment of benign diseases. But for the second point, we are not so sure. So we considered two scenarios. And we found that the direct medical cost of overtreatment ranged between 60 to 160 million euros overall in France. So how can we do to deal with it? First, we need evidence-based screening, and this encourages those non-indicated and non-evidence-based screening practices. And we need to increase awareness of health professionals and the populations. The Choosing Wisely campaigns in Western countries are very good examples of this. Shared decision-making. We need communication and open discussion between the patients and healthcare providers. Educational systems, both among healthcare practitioners and medical students. And for the healthcare systems, changes are needed in the financial and other incentives. And new technologies or biomarkers that can assist in distinguishing indolent and diagnosed cancers. And change terminology for those with a high probability of indolence. And the last one is watchful waiting or active surveillance. In this regard, we conducted a macro simulation model to assess the cost-effectiveness of active surveillance among those incidentally detected papillary thyroid cancer patients. And this was presented at the Assoc conference in the US and will be published soon. And we found actual surveillance can yield higher quality adjusted life years and less cost. And at least from the healthcare system perspective in China, active surveillance of incidentally detected early-stage papillary thyroid cancer is cost-effective. So to conclude, overdiagnosis is an emerging public health challenge and a barrier to effective cancer control, and is expanding very rapidly all over the world. With the advent of highly sensitive diagnostic technologies and the global enthusiasm for screening, overdiagnosis is expanding very fast. And we need collaborative effort to measure and monitor its magnitude. So I really look forward to have some collaborations here because I think local measurement is critically important. And healthcare practitioners, patients, and policymakers should all be involved in the prevention of overdiagnosis and overtreatment. With that, I would like to thank all my collaborators, without whom the projects would not be possible. And that ends my talk. Thank you.